And today we will discuss about bronchoscopy, and we will get lecture and main experience from Dr. Tushira, who have many time to perform bronchoscopy in ICU. And we hope that our connection today can more intensive, and maybe in the next future years we have meet offline, not online in this today. And we hope from your lecture today, Dr. Tusira, we can improve our services in our ICU in Malang and Indonesia. And the last, many thanks, and apologize for any inconvenience about our event today. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Ari. We are going to enter our main season of this webinar entitled The Role of Bronchoscopy in ICU, that will be delivered by our keynote speaker, Dr. Tusira, the Chief Physician of Clinical for Pneumonology, Respiratory, and Sleep Medicine at the Siloa at Strupped Hospital for Zain. To Dr. Tusira, time is yours.
Thank you very much. Thank you very much. Thank you for having me today in Indonesia and in Jakarta. And now I am going on air to be contacted with Malang. Thank you for having me, and thank you very much for giving me all the assistance I needed with your technical staff. I'm very sorry. Actually, the apologizers should be coming from my side, because due to my German systems, it was not possible to share my screen, and you helped me throughout the way and got me in. Thank you very much for everything, and for my apologizers too, that it did not function at the first side. But thank you. Do you know how much of time do I have for the lecture?
We have the time was 20 minutes for the presentations, and we forward for question and answer.
Okay, all right. Then I will do a 20 minutes lecture for you. So this is about bronchoscopy in critical care. So actually, to ask you the question, you all are anesthetists. So if you all are anesthetists and nurses and residents, have you ever seen the airways? This is the first question that I have to ask. Other than X-rays, other than computer tomography. So my first question is whether you have ever seen the airways. If you have not seen the airways, I assume it's a crime, because being the pilot in the ICU care and you have not seen the sky. So therefore, I assume bronchoscopy should be a part of the ICU, and by POC, it's a point of care to my extent and to my vision and to my knowledge. To come to the history of the bronchoscopy, the evolution of bronchoscopy and the endoscopy, this is the first ever made endoscope of the world. It was made from a German physician to go through the urogenital tract, also to the respiratory tract. He used a very easy way of having this, and with the candlelight, with the mirrors outside, he got the lights into the body cavity. So that's the first ever endoscope was made. His name was Philip Bozzini. And further on, one Dr. Kilian, Gustav Kilian, an ENT doctor, he's the one who did the first ever bronchoscope of the world. So the first ever endoscope was done in Germany. It was made in Germany, and the first ever bronchoscope was done in Germany and made in Germany. So the bronchoscopy and endoscopy is something very traditional in Germany, and it went throughout the world, as you know. So going to the facts. So these are the bronchoscopy pictures that I'm showing you. The earlier bronchoscopes, they did not have that possibility of doing big turns. And the newest bronchoscope, they get all the turns and tunes, and they are really naive at the moment. The bronchoscopy and its role at the ICU. We are talking about the diagnostic bronchoscopy, sampling bronchoscopy, and the therapeutic bronchoscopy. To the ICU, as a fact, the therapeutic bronchoscopy is a field that I wanted to take you around. why the bronchoscopy at the ICU? As an example, maybe the old doctors under you, as myself, because I practiced the last 30 years as a doctor, the first ever ultrasound scans about 20 years back, it was done by the radiologist. I mean, no physician used to do the ultrasound. Later on, the tracheostomy, it was done in the OTs, operation theaters. Now it is a bedside, percutaneous tracheostomy. And the renal therapy, the dialysis, it is a bedside at the ICU. So I ask you the question, if the ultrasound scan throughout the years to the physician, to the ICU, if the tracheostoma from the operation theaters to the bedside at the ICU, if the renal replacement therapies as such as dialysis to the ICU as point of care, why not bronchoscopy at the ICU to guide the weaning process and do the diagnostic? This is a fair question that I have to ask you, my dear ladies and gentlemen. So this is my endoscopy staff at my place. So starting my institution, 2005, I took over. We just did 2 interventions a year before that. In 2011, I got it out to 600 interventions a year. 2018, before pandemic season, 1,100 interventions. And the last year, we completed with 2,708 interventions. So just completing the month of January, we just finished with 320 interventions the last month only. So you are seeing we are doing a lot of interventions. Why do we do the lot of interventions bronchoscopy throughout the years? Why is that? Are we seeing different patients? Why is that? To tell you the facts, the reason is actually all the patient therapy procedures are getting faster and faster. Now we are into fast-track medicine, right? The years back, once you got the patient to the ICU, you had something like 20 days, 25 days, 18 days. That was a normal duration of a stay of a patient at the ICU care. But nowadays, actually, we finish the patients in 6 to 8 days. They should be out of the ICU care. So because this is resource management, so you need to have the weaning process accelerated. You need to have the therapeutic process accelerated. You need to have the microbiological assessment accelerated. So this is the reason why we do the bronchoscopy as a point of care at the ICU units all around the world, mostly in Germany and the rest of the world as well. So what are the purposes to use the ICU bronchoscopy? To diagnostic evaluation of respiratory disorders such as pneumonia, hemoptysis, when the lung cancer is suspected, or therapeutic interventions such as foreign body removals or airway stent placement. But the most important part is actually management of respiratory distress, such as mucus plugging and atelectasis. This is the reason, the mostly reason at the ICU care units where your patients need your assistance doing this. And there are new papers coming in. I can acquire you that. All the ventilated associated pneumonia to go with the better antimicrobiological strategies, we will be needing the diagnosis as such to perform the control BAL to get the microbiological assessment on your patients. So how can a bronchoscopy optimize the weaning process? So my dear ladies and gentlemen, we all are dealing with the weaning patient most of the time at the ICU care. From the very first day where you tube the patient at the ICU care, on that very first day, you start with the weaning. Normally, as you know, the 60% of the patients are straightforward path to extubate. 60% of the patients you get without any problems, you can extubate. But for 30% of the patients, you have a prolonged weaning procedures as they have difficult airway obstructions and are very difficult to extubate. So 40% of our patients are struggling with the weaning. From them, about 90% of them, they get tracheostomed. If a patient gets tracheostomed, you know, in these countries, it is difficult to do the post-demission patient management when they get home. So we have to prevent the tracheostoma rate at the intensive care unit. So this is one reason where we assume taking the bronchoscopy in the weaning percent, we can reduce the percentage of the patients who get re-intubated to prevent the tracheostoma, to get the patient without tracheostomas, without prolonged interventions, without prolonged weaning out of the ICU care. This is the reason why we do that. So going through some lung collapsing patients, once the patient comes, such as you see in the picture with the white lung on the left side, when they come to your intensive care unit or my intensive care unit, the normal conventional way is to tube them, because if they are struggling, if they are unstable, you have to tube them and then you have to ventilate them. In the moment even you do the blind suction, the bronchoscope is nothing other than suction with the vision. But if you just do the blind section, if you just can't remove the mucus plugs because you are doing it uncontrolled, and as you know, if you do the blind suction, always, most of the time, the tube goes to the right side. So in this case, if you do the blind section, if you can't acquire the mucus plugs, once you ventilate the patient with lot of pressure, you will press all the mucus plugs to the peripheral areas. This is one of the causes why the patients are getting ARDS. So therefore, to prevent that, we assume we do the rescue bronchoscopy. These patients, we don't tube, we go with the bronchoscope, we do the rescue bronchoscopy, and most of them with the NIV, with the HFNC, we get them without the interventional mechanical ventilations at the ICU care, out of the ICU care. So this is the reason why we say this is the time to get the bronchoscopy as a point of care unit to your ICU. So the most biggest problem is at the ICU is the people assume after performing the bronchoscopy at the ICU care, the patients, they get severe. The reason is actually if you do the bronchoscopy for minutes and minutes and hours, the patient will get instable. So therefore, you'll have to perform the interventional bronchoscopy at the ICU within 60 to 90 seconds. This is the target that we have to perform because it is just nothing else as a suction with a vision. So if you do the suction with the vision, you go inside the bronchial system, then if you can acquire the mucus plugs, then you come out of the interventional bronchoscopy after 60 to 90 seconds, nothing will occur to the patient. So this is the biggest clue, the biggest pitfall that we have to avoid. So this is a normal setting of the bronchoscopy ICU with the portable ICU bronchoscope, the turbo ICU from Richard Wolf. This is the unit that we have. We perform with that at every ICU just to go through. So as seeing the patients now with the white lung on the left side, doing the secretion, taking it out, the patient could be taken out. Now to the next subject, as the time is accelerating, to go to the pneumonia. So if the patient comes with pneumonia to our units, to our ICU care, the empiric therapeutical maneuvers that we have, applying antibiotics. This is the reason why we sometimes get the people on XDR and MDR antibiotic problems occurring, all the antimicrobial resistance diseases which are happening throughout the world at the moment. So what we say, if the patient comes with a lung signs like this, is it a viral pneumonia, as such as COVID, as such as influenza, as such as CMV, is a viral influenza, or it is an atypical microbiological disease, or is it TB? What is it are we treating? Are we treating the proper disease, or are you changing the antibiotics after 5 days, after 6 days, once again and once again, more and more antibiotic regimes, so that we develop the XDR resist germs and bugs? Or is it time to save life? Is it the ICU is time is life? So what we say is we ask you to do the first time bronchoscopy, do the BRL, and get the diagnosis done within a couple of hours. The multi-sequential PCR is available in 6 hours. Do the diagnostic, do the therapy. So this is the way to go through the correct way. And these are some pictures I'm showing you with the training centers that I have in Vietnam. These are intensive care units containing 128, 130 bedded units. All these patients are intubated and ventilated at ICU cares, as you see. So all these patients are suffering with diseases. So without the diagnostic, it is difficult to manage all these patients. That is what we say. So the antibiotic stewardship challenges that we have to take, they should be modified. They should be modified to my extent, actually, with the proper diagnostic, proper controlled bells to get the PCR done, to get the correct bugs done. So this is the way to go through in coming years, to do the proper PCR diagnostic, to do the proper microbiological challenges that we have to take with the antibiotic stewardship challenges in coming years. I will accelerate to do it. In another meeting, we can sort of go through all the specific the slides, because we just got 20 minutes. I think it's another 8 to 9 minutes more. So I will assume if the patient is there, they do the controlled vision suction, you can acquire all the mucus plugs, so the prolonged weaning should be reduced, and then you get the diagnostic in the same time, and you get the PCR sequence diagnosis, and then you apply the proper antibiotics. This is the accelerated way of treating the new patient at the modern ICU in coming world. So that is why we say, is it viral? Is it atypical? It is TB. What are we targeting at ICU? Time is life. Just get the PCR-based test on BAL and just do the correct treatment. So to go through the acute tracheobronchial obstructions, this is another reason why you should be having a point of care bronchoscopy at the ICU. The next patient is 85 years old, coming to the ICU care with aspirated food elements such as spaghetti in his case. So these patients should not be tubed because he's old, because if you go on weaning, this is a patient to be tracheostome otherwise. So therefore, we avoid the mechanical ventilation. We do the first time bronchoscopy. We aspirate all the foreign bodies taken out of the lung, and then we go through that. The next patient, this is a denture. This is the teeth denture, which was sucked inside. These are things which can all be taken outside using things. And another one of the big topics at the ICU care is the bleeding. The bleeding. How can you protect the bleeding? If the patient is coming bleeded, you tube the patient, you do the suction. But if you don't have the vision, you don't know where the patient is bleeding. You might be wondering, you might be harming the lesion too if you do the suction without vision. So therefore, we do the controlled bleed controlling with the bronchoscope. You can apply a suprarenin, you can apply a cold saline, you can apply the argon beamer or the laser to stop the bleeding. The other way of stopping the bleeding is taking the Fogarty catheter and blocking the specific areas to stop the bleeding. So I will show you this video. This patient who was coming, this is my training center in India. This is Sarja University. These people are trained. All these are anesthetists. Now they perform the bronchoscopy at the ICU. You do the suction of all these mucus plugs and all these blood plugs to prevent the prolonged ventilation. This is the way of, saving the patient from a prolonged ventilation. And the PCT, to go through the PCT or the PDT, as you call it, from the OT to bedside. This is the tracheostoma you do, and we do it bronchoscopy guided at the ICU unit to avoid a lot of falls, pitfalls, which can happen. We do the tracheostomy, everything controlled at the ICU unit. In my next session, I can go through the PDT, how to do it tracheostoma guided. I just want to give you a couple of impressions at the importance of the ICU bronchoscopy throughout coming years. So this is a PDT on bedside, doing it in, this was one of the Vietnam hospitals where we did on-site with bronchoscopy guided, and it is done. And the difficult airways, such as tracheostenosis, how to prevent them. If you diagnose a tracheostenosis, this is for the pulmonologist. This is not for the ICU anesthesiologist. These things should be led for the pulmonologist because you need their assistance. This is why we call the respiratory team with the pulmonologist and the anesthesiologist. Anesthesiology is managing the airways, doing the diagnostic and therapeutic bronchoscopy to avoid the obstructive airways. But if the obstructions are such severe as these, the pulmonologist should be taken into the picture, and they should be doing the cryobiopsies as we do them, and release the patient for the obstructed airways. The tumors, stenting, and all these things are patient treatment. So I will go to my last chapter. This is another patient who has come with a lot of mucus plugs to the ICU care. And how will you approach this case of respiratory failure? Would you do the conventional approach, tubing the patient and putting on high pressure ventilation, or would you do the rescue bronchoscopy as we do? We go the bronchoscopy on time. The patient is just sedated, and with the proper sedation, we go and release the patient from the mucus plugs and after taking the mucus plugs out of the lung system and then treating the patient with the rescue bronchoscopy, it's done, and they are not in the ventilated pattern. They are not in the mechanical ventilation. With the NIV, with the HFNC, you have the patient out of the intensive care. So therefore, we assume, we see the experiences, NIV, rescue bronchoscopy, and ECMO will be the modern way of treating the patient at the ICU care, other than using the invasive ventilation, which will get you the better outcome. And this paper, you might be knowing it, in May last year, it came out. All the COPD patients with the mucus plugs, they have a mortality specification of 50% of advantage if you do the mucus plugging, taking out control from the bronchoscopy. If you do it, the mortality rate goes down to 54% if the bronchoscopy done at the ICU care. So these are my training centers throughout the world. I will go fast. All these are mucus plugs, what you see. So all these patients who were there in that specific ICU care at Delhi, they are not tubed. All these patients are not tubed patients. They are done with the bronchoscopy, NIV, HFNC. They are prevented on a mechanical ventilation to be out of the resource management, to be out of the ICU care to get through. So outlook to the next level bronchoscopy, I will save it for the next time. So I think now you got an impression of the ICU bronchoscopy and why should it be a point of care unit at the ICUs in coming years. Thank you.
Thank you so much, Dr. Tushira. That's such a insightful sessions. And we can wait to moving forward for the discussion sessions. And do we have time? Maybe what about your time, Dr. Tushira?
I have time. I have
15
time. We
minutes
can
or
move.
20 minutes
time.
for
I have
answer
time.
and answer and question sessions?
I have time. I have time for a question sessions. No problem. No problem.
Or do you have more time for?
Pardon?
Dr. Tushira?
Yes. Yes.
Oh, did we have 15 or 20 minutes of your time for answer and questions?
Yes, I have. I have.
Oh, you have.
I have.
Okay, which will be conducts in several sessions for answer and question sessions. We will be have questions from the collecting the chat box or any audience raise hand. Maybe this one or someone is raising hand. Dr. Ari was raising hand.
Okay. Thank you very much, Dr. Tujira, for your lecture today.
Thank
As
you.
we know that from your lecture, so much useful of there are so many function of bronchoscopy in ICU, like for airway management, for solving mucus plug, and for getting sampling to solve infection. And from that, for to perform point of care bronchoscopy, maybe I have two questions. The first is, what should we be prepared to start point of care bronchoscopy? And the second question is, what is the most frequent complication if we perform a bronchoscopy in ICU, Dr. Tushira? Thank you very much.
Thank you, Ari. Thank you, Ari. Thank you very much for having me. First of all, it's a pleasure seeing you, man, once again. The thing is, actually, to be very frank, you all are anesthesiologists and you all are intensive care doctors. So you know the conditions of the patients, of the hemodynamics of the patients. You are the masters, right? I'm a pulmonologist, right? I am the director of the respiratory care and the ICU care, but still from my training, I'm a pulmonologist. So the pulmonologist, we just go to the airways and we do the diagnostic therapeutic, but we are not that familiar with the hemodynamics. So hemodynamics is your part. So actually, you know the conditions of the patient much more than better than the pulmonologist as we do. So telling you the fact why you should have it as a point of care instrument in your department is the reason, because if you have it, then you have the control of the airway systems, because if you do the suction without the vision, you are just doing the suction. But the vision gives you to have the insides of the airways. So therefore, this is out of a question why you should be having a bronchoscopy with the pulmonologist or without the pulmonologist. As a setting it gives you, but you should be having the bronchoscopy at the ICU care. So the biggest problem which can happen is nothing such as which you can't predict, because you don't do the bronchoscopy without reason. You do the bronchoscopy if the airways are unstable. So you go inside and see whether the mucus plugs are there. What do you do so as such? If you don't have the bronchoscopy, you do the suction, and you don't have that, I mean, preference of having the vision. So therefore, having the bronchoscope, it is not a danger. It helps you. You got the answer?
Okay. And how about the most frequent complication for
Actually, we prefer, I mean, if you take specimens, such as if you take specimens from a patient, such as lung specimens, right? Transbronchial specimens, then the pneumothoraxia and the bleeding is a complication, right? But we are not asking you to do the specimens. We are just asking you to do the bells. So there are no complications as such as. So if the airways are getting bad, if you think the patients are on higher PEEP, then don't do the bronchoscopy. But if the suction can be applied, you can apply the bronchoscopy anyway. Right? As an example, if the patient is, I mean, on the next or some other workshop, I can go into the details. If the one patient is struggling, if the FeO2 is decreasing, if the PEEPs are going up, why you should be doing the adjustment in the ventilator without seeing the airways, without knowing what is happening inside, right? We are just talking about 45-second, 60-second bronchoscopy, because you did that in Lampung, and you know with the tube patient, you are inside in 20 seconds, 30 seconds, and out in 45 seconds, right?
Okay. Thank you very much, Dr. Tusira.
Yeah, please. It's an honor.
Okay, all right. If there's any few questions, maybe from the audience, or get to know to each other to the breakfast. And Dr. Tusira, we are recording, and we are recording this Zoom webinar,
Yeah.
and then it will be linked with our YouTube channel. Is it okay for?
That is all right with me. I can offer you if you need. I mean, this was today the technical problems, and I just wanted to give you insights, but I can offer you, if it is needed, we can go structured lessons. I mean, we can do a kind of digital bronchoscopy. As an example, you have the bronchoscope at your end. I can help you with that. And with your departments, we can sort of do the anatomy first. And the first patient that is why that's how we normally do. And we go through the patient conditions, and then we do the one bronchoscopy. So it's like that we can gradually do one-to-one steps, right? It is just to give you the insights why you should be doing this.
That's really great. And then for the bronchoscopy, is it we have giving some sedation first,
Yeah,
like in
absolutely.
pneumonology or something?
Yeah. For the very good question, ma'am. The first thing is, the first bronchoscopy that you do is, if you don't have the bronchoscopy at the ICU as a point of care, on the ventilated patient, right? The first bronchoscopy you always do on the ventilated patients, because it's very easy to go through the tube. So this is just a suction with vision. So therefore, this patient is ventilated, then you don't have to do anything. Sometimes we just give propofol bolus. That is what we do, right? But if you want to do the awake patient, after doing 30 to 40 tube patients, then you are ready. The Dr. Ari is, I mean, he got the training. He can do the awake patient with the NIV as well. So the awake patient, we do with the NIV. So then you sedate the patient just with propofol. Just keep them awake. That is okay if they have the cough reflections. But you can, with the propofol, you're the anesthetist, so you people, you know how to do it and how to not to. But if these patients are getting severe and severe, you can tube them anyway, because you would have tubed anyway the patient, right? We want to prevent the tubing. So therefore, you can go with the propofol sedation and go through with the bronchoscopy. But the tube patient, of course, is not a problem as all, using little bit of propofol bolus.
Yes, that was, we really need for the sedation first before we are doing a bronchoscopy. And then we have very much people questions about what do we usually take any food or water before the bronchoscopy? Is there any difference between the pulmonologist or anesthesiologist for this one?
Once again, I did not get the second part of the question.
Did
Come
we, yeah, very much people asking us about the optimal time for the food or the water
Oh, yeah.
before
Yeah,
doing
all
the
right. Okay,
bronchoscopy?
absolutely. Yeah. The ventilated patient actually is not a problem, right? The ventilated. So all the first of all, the first I will guide you. The first bronchoscopies should be done in the ventilated patient, right? But if the other patient comes as aspirated or with the mucus plugs as a rescue bronchoscopy, we are talking about ICU care. So what is your situation? If a patient comes, is gasping for breath, is feeling unhappy and feeling uneasy, you tube the patient, right? So with the bronchoscopy, what we do is you do the bronchoscopy because you tube the patient anyway, right? But if you are on a pulmonologist, if I'm doing a cancer diagnosis, if I'm doing a interstitial lung diagnosis, if I'm taking the tissues, then we say overnight they should be fasting 6 to 8 hours, and then we do that because that is an elective intervention. It is not a rescue intervention, right? This is the pulmonology section. I will, if the pulmonologists are there, we can exchange all our experiences on ILDs, on all the tumors, all the stenting, all the ventilation procedures. We can do that. But the ICU is, we are talking about the emergency, right? So it doesn't matter if you are coming to my hospital, you have aspirated lung the mucus plugs or severe pneumonia. Before I tube you, I do the bronchoscopy and try to rescue you from that. So therefore, like the time limit of the water or food doesn't matter in the ICU setting.
Thank you so much. So it doesn't matter anything because the patient is in ICU already have a ventilator.
Absolutely, absolutely. Because if I want to tube the patient, I don't wait looking at the fasting hours.
So there's no fasting hours for the ventilator patients.
Yeah.
All right. Maybe the other audience, is there any questions?
Good afternoon, sir.
Hello, hello.
Okay. My name is Rofi. I'm in the second year of residency in anesthesiology.
Yeah.
I want to ask about, we know that the bronchoscopy we can use it for that mucus suction, targeted mucus suction, and then
Yes.
we can use it for airway, difficult airway, and then we can use it for targeted diagnostic for the PCR, and then what is the next step? What is the future and other thing that we can do with this bronchoscopy? Maybe your research for the next thing that we can use in ICU for bronchoscopy. Thank you.
Yeah, actually, one of the things are to do the PDT, right? You can use a bronchoscope without, bedside PDTs, right? If you're already doing it, that's good. If not, you can, the bronchoscopy PDT is more accurate than the ultrasound guided PDT, right? So to use the PDT, that is the next part. And the stenting, as an example, do the stents, do the other interstitial lung diagnostic. That is actually a part of pulmonology, right? Because actually the pulmonology should be taken in as long as we are doing tumors, we are recanalizing the tracheal systems and tracheal stents, bronchial stents, emphysema diagnostic. These are pulmonology department. The ICU department, if you prevent the patient from the re-intubation, if you have a very small numbers of tracheostoma patients, if you have a very advanced fast-track weaning systems guided with the bronchoscopy, it's the most part of the ICU bronchoscopy is done. You got the answer, sir?
Yes. So the part that really important for ICU part is to how we fast winning the patient.
Yes.
So
The
he-
airway obstruction.
he
You have to
or
get
she
control of
didn't.
the airway obstruction.
Yes, targeted suction. Okay. So, how he or she did not go to the prolong of the ventilator or tracheostomy. Okay.
Yeah, because the airway obstruction is the biggest cause for the ARDS. Airway obstruction is the biggest cause for the reintubation. So we have to get hold of the airway obstructions, right? And the second thing is you have all the microbiological aspects. I mean, not going through the XDRs and MDRs. I mean, have a very good the drug systems on the antibiotic stewardships, right? It should be guided. These are the main parts of the bronchoscopy at the ICU. Because bronchoscopy is not everything at the ICU, right? But as an anesthesiologist, as a weaning specialist, as a person of the airway manager at the ICU, I think you have to have the vision into the airways.
Thank you, sir, for the answer.
All right, thank you so much, Dr. Rafi. Maybe another participants wanna ask or something? Is there any best approach for the bronchoscopy or something if we have a defined from the tumor or the any cases, Dr. Tushira?
If you define what?
No, I mean, is that we have a best approach for the bronchoscopy, maybe from midline or maybe like for excisions of the mid tracheal tumor or anything?
Yeah, absolutely.
It's
Because,
it said it depend from the cases, so we have a best approach for
absolutely.
bronchoscopy.
Yeah, because actually, if
Is it maybe from nasal or from mouth?
yeah, absolutely. The normal, if the patient is tube, it is a reason is specifically clear, right? But if you do the awake bronchoscopy, we always advise to go through the nasal way, because to approaching the nasal way is the easier way, right? Because the tongue is not in the way, and it is anatomically easier to approach the trachea system through the nose, right? So the rescue bronchoscopy, what we say to acquire the BIL diagnostic or the mucus plugs, we go through the nose, right? But if it is not happening, then you go the oral way. For the tumor diagnosing, this is the pulmonology should be taken in. It should be done with the tube, with the oral way. That is what we say. Because if you occur a big bleeding with the tumor, then you have the better management if you have the tube inside.
All right, thank you so much. There is any residents for the asking?
Sir, I want to ask a question again. You
Yes.
said that the optimal time for the bronchoscopy is 60 to 90 seconds, if I'm not mistaken. 60 to 90, right? What is the tips and trick to do the fast?
Yeah.
I mean, let's take a.
Yeah, that's training. That's a very good question what you asked, because one of the biggest problems is the people, they don't, I mean, take care of the time, right? I mean, if you are a trained doctor, anesthesiologist, intensivist or pulmonologist, then you can spend time on the airways as much as you want. For the first time, I always tell my training doctors on the first time, even digitally or non-digital, I say, you go through the tube just for 30 seconds, just go inside, just have a look at the main carina. Normally, if the tube is inside, you are there on 7 to 8 seconds because you're just going through, right? And then you go to the right side, you just go to the left side, just do the suction and come out. I will assume it will just take you 40 seconds because you are just having the weave. Then after that, you ventilate the patient, you wait a couple of minutes, and once the saturation levels are bit up, you go once again. And if you target the area as right or left lung, you go there and do the suction and take the specimen and come once again out. This is a fractional way of doing. If you are not trained at first, just be there 45 seconds on your first bronchoscopy and finish it, wait, go once again. Every time, only 40 to 45 seconds. So because the hemodynamics are stable. When you are trained enough, then you can have 90 seconds. It's a big time. You put the stopwatch, I will show you that 90 seconds is a big time, right? You have a lot of time. 2-3 minutes of bronchoscopy at a stretch. That is, you do it when you have done 20, 30, 40 bronchoscopes, then you know the hemodynamics are stable. You are pretty sure with the anatomy, so then you can master the procedure, so then you are ready enough. It's a very good question, sir. It could be trained. As an example, what does a nurse does if she does a suction without the vision? She doesn't stay in the lung for 2-3 minutes, right? She just go inside and do the suction and come out. So why don't we do that with the vision?
Okay, that's we do it small time, but a few times. Okay, not one time, but long time.
If you do
I
it the
understand.
first time 4-5 minutes, it's difficult to get the patient. So better go it fractionally.
Okay, I understand. Thank you, sir.
There's any questions from the residents? Maybe Dr. Triara?
Okay, thank you, Dr. Shada. Dr. Tushira, may I question to you about, I want to know about what if we do the bronchoscopy procedure in pediatric patients? As we know, it is quite challenging to perform the bronchoscopy in pediatric. Maybe the size is not properly. And then, so my question is, what is the difference between the technical procedure between the bronchoscopy in adults and pediatric? And then are there any attention we should pay to during the pediatric bronchoscopy? Thank you.
Oh, I mean, I got a very good audience today. Thank you very much for joining in, because your questions are very good, right? I will explain you. You can see me, I hope, right? So if the patient has a tube, as an example, if the tube is 8 gauge, right? The bronchoscopy should be always 2 millimeters less. If you have the tube of 8 millimeters, the bronchoscopy, the biggest size what you can take is 6. If the tube is 7.5, the outer diameter of the bronchoscopy should be always 2 millimeter less. This is the proper specifications. So the pediatric patients, you should be having the smallest bronchoscope, depending on the patient's age. The smallest bronchoscope, which can do a suction and give you the vision, is the outer diameter is something like 2.2, 2.4, right? So the tube size can't be less than 4 millimeters. So if the tube is less than 4 millimeters, it's difficult to do. I hope you got the answer.
Okay, so if less than the tube, less than 2.5, we cannot do the bronchoscopy in pediatric. Is it right?
There are very minimalized bronchoscopies are there, right? Very minimalized ones, which you just give you the inside. You can just see the side. There are no working channels, just to look inside whether you are in the lungs or not, right? That is possible. But if I'm not a specialist in pediatric pulmonology or pediatric intensive care, because in Germany the systems are different, because we have to treat all the patients are above 18, right? But I have done some pediatric patients in aspiratic problems, right? If the foreign bodies are there, then we go with the rigid bronchoscope, and the patient, this is a pulmonology interventional. We go with the rigid bronchoscope, and with the rigid bronchoscope, you take the aspirated bodies one by one. But this is not ICU bronchoscopy, right?
Okay, thank you, Dr. Rushira.
Thank you for the good question.
Such a great questions and a good answer. So it's 2 millimeter less, and then smallest bronchoscopy depend on the age for the children.
Always a bronchoscopy should be 2 millimeter less, then you have enough space to work. So therefore, once you tube the patients, right, this is something we don't practice that much in Asia. Don't take the 7.5, try to get the 8 always, because it's a better outcome, the better airway trapping, everything is better with the 8. But if the 8 can't be intubated, then you go with the 7.5 or 5, right? 7.5 or 7, right? But then the bronchoscopy should be outer diameter 5 or 6, nothing much than that.
All right, thank you so much. So, is there any questions? Maybe Dr. Zan Aris.
Thank you for the opportunity. I want to ask about is there any different techniques or or ways uh, with patient with intubated and not intubated we can do with bronchoscopy?
Yeah,
Thank you, sir.
very good question. Actually, I think in coming years, right? These are my experience. I do the bronchoscopy last 30 years. I think coming years, the video laryngoscope will be what we wanted, because a video laryngoscope just give you the insight to see how inside, right? But if the patient is difficult to intubate, what we do is we take the tube, we put the bronchoscopy in the tube, and the tube is guided with the bronchoscope, and with the Feldnicker technique, we go inside. That way, the bronchoscopy guided intubation is much easier to you.
So that we can use the laryngoscope to guide the bronchoscope and
Actually,
inserting the
you don't have to. You don't need the laryngoscope, because you have the mouth block. With the mouth block, with the bronchoscope, you go oral way, then you have the vision. Actually, laryngoscope not needed at all.
Oh, yes. I get it. Thank you, sir.
All right, thank you so much. Is there's any questions?
May I have question again, Dr. Syuhada?
Yeah, please, Dr. Ari.
We know that most ICU patients are ARDS, pneumonia, bacterial pneumonia, and viral pneumonia like COVID-19. And according your experience in such a patient, what is the difference about what it's different maybe from the mucus, from the sputum, and from the quality of mucus of bronchus if we perform bronchoscopy in such patient like ARDS, pneumonia, and COVID-19 patient.
Yeah.
Is it any different from this patient, Dr. Tushira?
Good question. Good question, Ari. I have a small problem. In 8 minutes, I will be picked up for the next meeting, right? But I will answer the question. Don't worry. This is a very question, because as COVID, actually, we can do another meeting next week, or another session. We can make a curriculum. We go one by one. As COVID came, the first ever, the patients were not advised to do the bronchoscopy because everybody was scared, right? But we were one of the institutions in Germany. We started the bronchoscopy directly. The COVID mucus is very, very much associated with fungus, right? With a lot of fungus, with aspergillus as an example. So the COVID mucus is very thick. It's very viscous, very thick. So this was one of the reasons the patients with the COVID infections, they could not cough out the mucus plugs. That's why they developed, as an example, also ARDS. So there are some viral infections such as COVID. They are very thick mucus plugging. And the atypical bacteria, such as mycoplasmas, such as Legionella, they also have very thick mucus plugs. The other advantage in the bronchoscopy, if the patient are on RRDS and a typical RRDS without mucus plugs, right? If you go through the airways, you see always dry airways. If the CT structures are disastrous, if the CT structure is absolutely done, it is very, very milk glass atmosphere, and you go to the bronchoscopy, you go to the airways, it's dry, then it's a typical ARDS, hands off. Then you identify, because if the inside is dry, outside is completely driven, then it's a typical ARDS. It's not a mucus plug ARDS, right? So you can also have the ways of ARDS, which kind of ARDS we are dealing with.
Thank you, Dr. Tushira.
No problem, sir.
Thank you so much, Dr. Tushira. Dr. Ari, if there's any last questions maybe from Dr. Benny?
Hello, okay, doctor. I want to ask about question. If we have the patient with suspected acute lung edema, or the patient acute lung edema with ventilator support, there is a high PEEP of this patient. Is there any contraindication we do the bronchoscopy to make sure this patient is pure? The worsen is allo or pneumonia or something else? Because we think about how we get the lost PEEP with the patient with high PEEP for the patient suspected allo, doctor. Okay, doctor. Thank you.
Yeah, actually, the always the indication, because don't ever see you as a student, right? Because you all are trained doctors, you all are anesthesiologists, and you can, I mean, deal with the airways, you can deal with the hemodynamics. If the patient is with the lung edema, the indication for the bronchoscopy should be given. Because if it is not given, you don't do the bronchoscopy. If the patient is clear on lung edema, there is no reason to do the bronchoscopy. Why you should be doing a bronchoscopy on a lung edemic patient, right? The patient where you do the bronchoscopy is where you think there are a lot of mucus inside and your PEEP is going up, your FeO2 is going up, then you know there is something happening in the airways. It is only lung edema. You have done the echo scan, you have done all the hemodynamics, and still you are not sure whether it is only isolated lung edema or is it always combined with the pneumonia. That is a reason to go inside and watch only in that patient. But you go there, as I said, sir, 30 seconds. So what can happen in 30 seconds? If a nurse goes inside with the tube, do the suction, what can happen if you go with the bronchoscopy with 30 seconds? Because we are doctors, we are scared to do an intervention because if something happened, the doctor did that. This is the thought block that we have to go through. The thought block, we should not be scared. This is the thought block that we have to fight.
Yeah, thank you so much for the questions. And then Dr. Tushira, thank you so much
Thank you.
for
Thank
this
you.
wonderful conference. I
Thank
really
you.
enjoyed
Thank
to
you. Thank you.
talk about the role in
Yeah.
bronchoscopy in ICU.
I have one more comment to do, right?
Mhm.
I do now actually the bronchoscopy at the ICU, one of my missions. I want to take it throughout the world, right? But in Indonesia, a very special pace, right? Because this is something like becoming home for me, because you have great doctors and they are very enthusiastic and they have a lot of power and empowerment and spirit. So I really, really appreciate this. And sorry for the technical inconveniences we had earlier. So I think the next time it shouldn't be a problem at all. Thank you.
We are so sorry too for the
No problem.
trouble
No problem.
with
No
signal
problem.
interference.
No problem.
And then maybe we can take a picture first.
Yeah.
We ask all the participants to open their cameras because we all having a group photo sessions.
Oh, great. We do that.
All right. First slide. For the others, maybe other participants, let's open the camera because we will having a group photo sessions. All right. The first slide, 1, 2, and 3. All right. And then the second slide. 1, 2, and 3. And then third slide. 1, 2, and 3. Finally, I would like to thank you so much for Dr. Tushira as our keynote speaker who shared their fellow experience at plenary sessions, all the others, and then all the contribute. I do hope this webinar is able to impact us for greater and foster empowering society, especially in ICU, intensive care unit. And please keep in that mind, we still have a various session afterwards. And then to conduct, thank you so much for great contributions and looking forward to seeing you in the next webinar, Dr. Tushira.
Thank you. Thank you. Thank you.
Thank you very much, Dr. Tushira.
I'm sorry. Thank you. Thank
Have a
you.
nice journey in Indonesia and Jakarta and Lampung.
Thank you. Thank you. Thank you. Next time I'll come and visit you. Thank you.
Okay.
Yeah.
Thank
We
you.
will wait for you to doing the bronchoscopic in our hospital.
I will come. I will come.
Okay.
Thank
Thank you
you so
very much. Thank you.
Thank you so much for all the audience. And then we will finish the webinar.
Yuk.
And then, ya dok.
Wah, kok masih bahasa Inggris, Syu?
Ya, siap dok. Saya pikir
Bahasa Indonesia aja, Syu.
ya dokter. Mungkin